Good day, class. For our meeting today, we're going to tackle your lesson for WBC abnormalities. Now, your WBC abnormalities are divided into two. Let's tackle the first one, the quantitative abnormalities. The quantitative or distributive leukocyte disorder. So, this refers to the value class or the amount of WBCs in your body or in your circulation. Now, those are not caused by clonal or neoplastic changes in hematopoietic precursor cell, meaning class there is no qualitative abnormality. This is just based on quantity. Now, causes can be genetic or acquired and involve one or more lineages, such as the neutrophil, lymphocyte, monocyte, eosinophil, and basophil, affecting the number of circulating cells, morphology, or both. Now, we have the so-called mechanism of leukocytosis. Leukocytosis meaning increase WBC. Increased movement of immature cells from the bone marrow proliferative compartment. So when your body class continuously produce immature cells known as your blasts, they would go to the from the bone marrow and into the circulation. Increased mobilization from maturation storage compartment to circulating pool. Increased movement from marginating pool to circulating pool, and decreased movement from circulation to the tissue. So your WBCs class, if you still remember, are capable of performing diapedesis. So they would move in the tissues, yung marginating pool to the circulating pool. Now, let's start first with the quantitative abnormalities in the first lineage, yung neutrophils nyo. Now, take note that the relative neutrophil, if you still remember in your differential count, diba, we have your relative and absolute count. Now, the relative neutrophil count class is usually 50 to 70%. In your diff count, remember you're required to count 100 WBCs. Normally, out of those 100, 50 to 70% should be neutrophils. That's the normal count. While your absolute neutrophil count is approximately 2 to 7.7 times 10 raised to the ninth per liter. Now we have the so-called neutrophilic left shift, characterized by the presence of immature cells in the myelocytic cell line. This would include metamyelocytes and myelocytes in addition to the band and segmented form. First, we have your neutrophilia. Now, neutrophilia is an absolute increase in neutrophils greater than 7 times 10 raised to the ninth per liter in adults, or 8.5 times 10 raised to the ninth in children. Now, mechanisms of neutrophilia class would include catecholamine-induced shift in neutrophils from the marginal pool, cells normally adhering to the vessel wall, to the circulating pool. So if a patient or if a person takes catecholamine drugs class, this can induce increased neutrophil, increase in bone marrow production of the neutrophil series, transfer of neutrophils from the bone marrow storage pool to the circulating pool. Itong increase in bone marrow production of the neutrophil series class, these are usually seen in bacterial infections. In bacterial infections, it is expected that you would have higher neutrophil count, then often accompanied by a left shift. Other causes of neutrophilia class could be physiologic. So if a person is under stress, undergoing extensive or exhaustive exercise, smoking, pregnancy in newborns would tend to have higher neutrophil. Acute inflammatory seen in collagen vascular and vasculitis. Acute infection seen in bacterial, viral, fungal, and parasitic. Drugs, toxins, and metabolic seen in taking corticosteroids, growth factor, uremia, and ketoacidosis. Tissue necrosis usually seen in burns, trauma, MI, RBC hemolysis. Neoplastic will include carcinoma, sarcomas, myeloproliferative neoplasm. Then we have your diurnal variation. So neutrophils would tend to be higher in the afternoon and lowest in the morning. Then we have the different types of neutrophilia. We have your reactive neutrophilia. This is an increase in neutrophil due to a physiologic or pathologic process. We have the first one, yung immediate neutrophilia. This is pseudoneutrophilia or shift neutrophilia, a distribution of the marginated granulocyte pool to the circulating granulocyte pool. Transient lasts for 20 to 30 minutes, caused by active exercise, epinephrine administration, or anxiety. Then we have your acute neutrophilia, which would occur 4 to 5 hours of pathologic stimulus like bacterial infection or toxin. Immature forms would appear in the circulation. Then we have your chronic neutrophilia, which would follow acute neutrophilia. Increase in the circulation of immature form, shift to the left. Then you have your leukomoid reaction versus leukoerythroblastic reaction. Now, for you to remember this class, if it's a leukomoid reaction, this is a benign leukocyte proliferation characterized by a total leukocyte count of greater than 50 times 10 raised to the 9 per liter, with many circulating immature precursor, usually caused by severe infections such as tuberculosis or necrotizing tissue such as lung, stomach, breast, or liver cancer. Then produces a blood picture similar to your chronic myeloid leukemia, but unlike leukemia, it is transient class, meaning it is not permanent. It moves or it disappears when the stimulus is removed. While your leukoerythrocytosis is the presence of nucleated erythrocytes and a neutrophilic shift to the left in the peripheral blood. Total neutrophil count may be increased, decreased, or normal. Red cells in this condition would exhibit poikilocytosis with dacrocytes and anisocytosis. Then you have your leukoerythroblastic reaction, most often associated with chronic neoplastic myeloproliferative condition, especially myelofibrosis, myelophthisis, and severe hemolytic anemia, such as your RH, hemolytic disease of the fetus, and newborn. Now, take note, class, that your leukoerythroblastic reaction would involve both immature RBC and WBC, or blasts and nucleated cells seen in the peripheral blood, usually a result of myelophthisis or replacement or infiltration in the bone marrow. If cancer cells infiltrate the bone marrow, immature RBCs and WBCs may exit the bone marrow. Then we have another abnormality in relation to neutrophil, yung neutropenia class. This is a decrease in the absolute neutrophil count of less than 2 times 10 raised to the 9 per liter in adults, or 1.3 times 10 raised to the 9 in black adults. Risk of infection increases if it is less than 1 times 10 raised to the 9 per liter. Neutropenia is characterized by zero point 0.5 times 10 raised to the 9 per liter, which further increases the risk. Then we have your agranulocytosis. This is the absence na class of your granulocyte or your neutrophil, characterized by a neutrophil count of less than zero point 0.1 times 10 raised to the 9 per liter. So these are the mechanisms of neutropenia. Increased rate of removal or destruction of peripheral blood neutrophil, fewer neutrophils released from the bone marrow, usually caused by decreased production, ineffective hematopoiesis. Neutrophils are present in the bone marrow but not released into circulation. Decreased ratio of circulating versus marginal pool of neutrophil. More on marginal pool, less on the circulating pool. Causes of neutropenia class would include drugs such as your cancer chemotherapy, chloramphenicol, sulfas, and other antibiotics. Radiation, toxins such as your alcohol, benzene compound. Intrinsic defects would include Fanconi's, Costman's, cyclic neutropenia, Chidak-Higashi. Immune-mediated, usually seen in collagen vascular disorder, rheumatoid arthritis, AIDS. Hematologic, seen in megaloblastic anemia, myelodysplasia, marrow failure, and marrow replacement. Infections would include any overwhelming infection, Others would include starvation and hypersplenism. Then there's the causes of spurious or false neutropenia. False neutropenia class would usually occur or possibly occur when you are trying to collect the blood sample. This is usually seen in EDTA-induced neutrophil adherence to RBC, disintegration of neutrophils over time prior to testing, then disruption of abnormally fragile leukocyte during preparation of the blood for testing, and neutrophil aggregation. Now let's go to your eosinophils class. So for eosinophils, you have to consider the factors that would affect the number: bone marrow proliferation rate and release into the bloodstream, movement from the blood into extravascular tissue, cell survival and destruction after eosinophils have moved into the tissue. Now let's start with the first one, eosinophilia. This is an absolute eosinophil count of greater than zero point 0.4 times 10 raised to the 9th per liter, usually caused by allergic reaction, inflammatory, and parasitic infection. So causes of eosinophilia are usually seen in allergies such as urticaria, hay fever, asthma. Seen also in inflammatory conditions such as your eosinophilic fasciitis, Churg-Strauss syndrome. Parasitic seen in trichinosis, filariasis, and schistosomiasis. Non-parasitic infections such as systemic fungal, scarlet fever, chlamydial pneumonia of infancy. Then we have your respiratory seen in pulmonary eosinophilic syndrome such as Loeffler's, tropical pulmonary eosinophilia, Churg-Strauss syndrome. Then there's also your neoplastic seen in chronic myeloid leukemia, Hodgkin lymphoma, and T-cell lymphoma. Then we have your idiopathic hypereosinophilic syndrome, which would affect the heart, the liver, the spleen, the CNS, and other organs. Other possible causes would include drugs, hematologic and visceral malignancies, gastrointestinal inflammatory diseases, sarcoidosis, Wiskott-Aldrich syndrome. Then you have your eosinopenia. This is an absolute eosinophil count of less than 0.09 times 10 raised to the 9 per liter. Causes would include decreased production, acute bacterial infection, and ACTH administration. Now let's go now to the third one, the basophils class. So we have basophilia. This is an absolute basophil count of 0.15 times 10 raised to the 9 per liter. Usually seen in myeloproliferative diseases, in allergies to food, drugs, and foreign protein, infections such as your variola, varicella, chronic hemolytic anemia, especially post-splenectomy. Inflammatory seen in collagen vascular disease, ulcerative colitis. Then we have your vasopenia seen in acute infection, hyperthyroidism, and increased glucocorticoids. Then let's go to the fourth one, the monocytes. So under monocytes, quantitative disorder is your monocytosis. This is an absolute monocyte count of greater than 1 times 10 raised to the 9 per liter in adults and 3.5 times 10 raised to the 9 per liter in neonates, associated with numerous conditions because of their role in acute and chronic inflammation, immunologic conditions, hypersensitivity reaction, and tissue repair. So when your monocytes class are increased, they tend to be more general. They are increased in a lot of disorders. They are often the first sign of recovery after myelosuppression, seen in congenital cyclic neutropenia. Monocytosis occurs during periods of neutropenia in the 21-day cycle. Causes of monocytosis class would be seen in infection such as tuberculosis, subacute bacterial endocarditis, syphilis, protozoan, rickettsia. Recovery from neutropenia. Hematologic seen in leukemias, myeloproliferative neoplasm, lymphomas, multiple myeloma. Inflammatory seen in collagen vascular disease, chronic ulcerative colitis, sprue, myositis, polyarteritis, temporal arteritis. Others would include solid tumor, immune thrombocytopenic purpura, and sarcoidosis. Then we have your monocytopenia. This is an absolute monocyte count of less than 0.2 times 10 raised to the 9 per liter. Very rare in conditions that do not also involve cytopenias of other lineages, such as aplastic anemia or chemotherapy-induced cytopenia. This is found class in patients receiving steroid therapy or hemodialysis and even in sepsis. It also occurs in viral infections involving Epstein-Barr virus. Profound monocytopenia is found in hairy cell leukemia. Then the last one would be the lymphocytes. So usually take note of this class if it's children. Children would tend to have higher absolute lymphocyte count. For adults class, the one that is higher would be neutrophils followed by lymphocyte. But if it's children, the highest number of WBCs would be the lymphocyte followed by neutrophil. Adults represent 20 to 40% of circulating leukocytes. So 20 to 40% ang lymphocytes. But for children class, due to the size of their thymus. So increased size of thymus means increased maturation development of T cell. If you remember, di ba yung mga lymphocytes nyo, they could either become a T cell or a B cell. If it's in the thymus, they become B cells. If it's in the bone marrow, they become B cells. So because of the large size of the thymus, more T cells are being produced. Over time, the thymus would shrink. That is why adults have smaller thymus. Now let's go to the different variations. The first one is lymphocytosis. This is an absolute lymphocyte count of greater than 10 times 10 raised to the 9 per liter in adults and 5 times 10 raised to the 9 per liter in children. Usually accompanied by changes in lymphocyte morphology. Causes of lymphocytosis, infections. Many are viral, pertussis, tuberculosis, toxoplasmosis, rickettsial. Chronic inflammatory, seen in ulcerative colitis and Crohn's disease. Immune-mediated, drug sensitivity, vasculitis, graft rejection, Graves' disease, and Sjogren's syndrome. Hematologic is acute lymphoid leukemia, chronic lymphoid leukemia, and lymphoma. Stress, acute and transient. Then we have your lymphocytopenia. This is an absolute lymphocyte count of less than 2 times 10 raised to the 9 per liter. Whereas in adults, it is 1 less than 1 times 10 raised to the 9 per liter. Causes of lymphocytopenia would include destructive, seen in radiation, chemotherapy, or corticosteroids. Debilitative would include starvation, aplastic anemia, terminal cancer, collagen vascular disease, and renal failure. Infections would include viral hepatitis, influenza, typhoid fever, and TB. Then we have your AIDS associated, seen in HIV cytopathic effect, nutritional imbalance, and drug effect. Congenital immunodeficiency, seen in Wiskott-Aldrich syndrome. Abnormal lymphatic circulation, seen in intestinal lymphangiectasia, obstruction, thoracic duct drainage, rupture, and your congestive heart failure. Now we're done with the quantitative. This time, let's go to the qualitative. So when we talk about qualitative class, there's an abnormality in the function and even the number. This includes morphological abnormalities involving the cytoplasm, nucleus, and granules of the WBC. Let's start with the first group, the congenital defects. So these are usually inherited or seen in newborns class. We have the first one, your SCID. SCID stands for Severe Combined Immune Deficiency, wherein circulating T and natural killer lymphocytes are nearly absent. B cells are adequate number but are dysfunctional. Then you have your Wiskott-Aldrich syndrome. T cells are decreased. B cells, T cells, and NK cells, neutrophils, and monocytes are dysfunctional. Leads to bacterial, viral, and fungal infection. And there's also the presence of thrombocytopenia. Then you have your 22q11 syndrome. This is an absence or decreased size of the thymus, low numbers of T cell. Then you have your Bruton tyrosine kinase deficiency. This is a primary immunodeficiency disease class characterized by the reduction in immunoglobulin isotypes and profoundly decreased or absent B cell. Then you have your Chidak-Higashi syndrome. These are giant lysosomal granules in granulocyte, monocyte, and lymphocyte. The reason why they have a giant lysosomal granule class is because the lysosome granules fuse together, resulting in this dysfunction. Bleeding issues as a result of abnormal dense granules in platelets. Congenital defects of phagocyte. This is a rare group of genetic diseases characterized by low neutrophil count, increased risk of infection, organ dysfunction, and a high rate of leukemic transformation. Then we have your leukocyte adhesion disorder, defects of motility, inability of neutrophils and monocytes to move from circulation to the site of inflammation. Then we have your defects of the respiratory burst. You're familiar with your CGD or your chronic granulomatous disease caused by the decrease in the ability of the neutrophil to undergo a respiratory burst after phagocytosis to foreign organism. Remember, class, your neutrophils are capable of performing phagocytosis or yung tinatawag nilang or what they call cell eating. Now, once they have engulfed the foreign pathogen, they need to break it down or they need to destroy it or dissolve it by using certain organisms, yung hydrogen peroxide and so on, known as the respiratory burst. Now, the problem with your CGD is that there's a defective respiratory burst causing the organism to not be removed, leading to an abnormal neutrophil. Then we have your WHIM syndrome, characterized by warts, hypogammaglobulinemia infection, and myelokathexis syndrome. Neutrophils accumulate in the bone marrow, so they stay in the bone marrow class, results in low number of circulating neutrophil. Retained neutrophils in the marrow exhibit degenerative pycnotic morphologic changes. Now let's go to the morphological abnormalities of leukocyte without associated immunodeficiency. We have the first one here, Pelger-Hewitt anomaly, decreased nuclear segmentation. So this is a hypo-segmented neutrophil class with distinctive coarse chromatin clumping pattern. Potentially affects all leukocyte, most obvious in mature neutrophil. So yung mga mature neutrophil nyo are hyposegmented, usually bilobe form, with the nuclei attached by a thin filament. Then we have your neutrophil hypersegmentation. Neutrophils have more than 5 lobes, often associated with megaloblastic anemia. Also seen in myelodysplastic syndrome, where they represent a form of dysplasia. Then you have your Alder-Riley, characterized by granulocytes with large, darkly staining metachromatic cytoplasmic granule. Then you have your May-Heglin anomaly, characterized by a variable thrombocytopenia, giant platelets, and large dull body-like inclusions in neutrophils, eosinophils, basophils, and monocytes. Then you have your lysosomal storage disease, group of more than 50 inherited enzyme deficiency, resulting from mutations in genes that code for the production of lysosomal enzyme. Flawed degradation of phagocytized material and buildup of undigested substrate within lysosome causes cell dysfunction, cell death, and a range of clinical symptoms, such as diseases would include Gaucher disease class and your Niemann-Pick disease. Now, I want you to memorize this summaries class. These are the summaries of the different qualitative disorders and their associated conditions. So do memorize them. They will definitely come out in your quiz. So that ends the lesson for your WBC abnormalities. Here are the references. Thank you.